Hi. Good morning, everyone. It's my pleasure to be here. My name is Silvia. I'm the Integrated Health President. I'm glad to chair this very important section on nutritional challenges, guidelines, and developments, where we are going to listen to a very renowned speakers and with a very good points on nutrition and guidelines. And I am glad to see that the room is full of people. Like we had yesterday, a very good section on integrated health, and I'm happy to have you here. So I'm going to chair, and the moderators are going to be Dr. Fiona and Katie, and we are going to begin the section with the introduction of the first speaker.
Good morning, everybody. I'm delighted to invite Mary O'Kane up to talk about nutritional guidelines. Do we have sufficient evidence and a practical view? Thank you, Mary.
And I'm going to take a picture of our very large audience as well. So, and it helps support for more integrated health sessions in the next conferences. Not sure I'm holding it right. So it's a real pleasure to be here today. I've got no conflict of interest associated with this. So we have many guidelines across the world, and you could argue, why do we need more? We have the SMBS, we have our UK guidelines, French guidelines, I know Spanish guidelines, ones from Israel, India. And certainly what we found when we were looking in the UK is that other people's guidelines actually didn't meet the needs of our services on our healthcare. So I think guidelines are really important, but also remembering that we've also devised them, how to develop them in different ways as well. We have talked about whether we need guidelines that will meet the needs of everyone, and if so, and I think it's really important to remember we're a global organisation with different healthcare needs, but also we have different public health issues. So if we look at the prevalence of anemia in non-pregnant women, this is not obesity, and what you can see, the prevalence is very different across the world, from about 5% in the UK to much higher in other countries. Similarly for vitamin A deficiency. So vitamin A deficiency is a public health issue in many Latin American countries and also in India, where we'd rarely see it in the UK. And also for zinc deficiency, certain countries have higher prevalence. So when we're looking at guidelines, especially on nutrition, that meets the needs of the whole population and also people living with obesity, I don't think one size fits all. When we're looking at guidelines as well and looking at the evidence is a real challenge. And the surgical procedures, but a rheumatoid gastric bypass done by two different surgeons may be a very different operation depending on limb lengths. Got one anastomosis gastric bypass, the length of the bilipancreatic limb is going to affect the absorption. If you've got a duodenal switch or the SADIS, again, the length of the common channel is going to have an impact. Then when we look at the range of studies, there's not many RCTs done in bariatric surgery and nutrition. And if they are done, tend to be quite short term. So we end up looking at prospective studies, case controls, case series, small cases, and that contributes to our evidence base. And then also, when I was doing guidelines development, you look at the studies and you think, well, did this person have iron deficiency anemia before surgery? Was it corrected? And so people are actually often entering into surgery with existing nutritional deficiencies. So we don't know if the surgeries caused them and made them worse, or whether they developed after surgery. Length of time of follow-up. I get really excited if I see 10-year follow-up, and then I realise that hardly anybody has been followed up at 10 years because the numbers have dropped significantly. And then because people are reporting their own research, and I'm not criticising them for doing that because they're doing it in their own time they're not being supported, and also it's hard to follow people up. So we lose people, they move to different areas, and so it can be hard to get the information. And also if you're in a service like ours in the UK, where you're only commissioned to give 2 years follow-up, it's hard then to see what happens at 5 years and 10 years. And then vitamin and mineral supplements differ completely. And I know, for instance, in England, a certain vitamin that we use, if that is in Ireland, it'll be a different composition. And certainly some of the ones we use in England, in the Republic of Ireland, we can't get, and vice versa. So that makes it also difficult to interpret. When I'm looking at evidence as well, I'm looking ahead to updating the BOM's nutritional guidelines. And I was really excited when I saw the systematic review on vitamin D, and I thought this is going to make my life so much easier for the review. However, when I started to look at the paper, and it is a very, very good paper, and I would recommend it, you can see where there's maybe gaps in the evidence base. So when we look at pre-op monitoring, everything is based on non-comparative observational studies, but they all tend to be saying the same thing. And we know that many people have vitamin D deficiency, and we also know that many people with obesity have vitamin D deficiency, so it makes sense to monitor. Post-op again, afterwards, it's mainly observational studies. Now, in this paper, what they did was they also looked at the band and the sleeve gastrectomy and the wide gastric bypass and the duodenal switch. And what I found quite puzzling, they've classed the band and the sleeve as restrictive and the bypass and the duodenal switch as malabsorptive. Now, the sleeve does have some malabsorptive elements to it, especially with micronutrients. The wide gastric bypass and duodenal switch are very, very different in how they work. So malabsorption is a greater problem in the duodenal switch than is the wide gastric bypass. So for me as a dietitian, clinically with experience of both procedures, I find it odd that that's how they classed it. And then when you start to look at then the implications, the recommendations, it's really important. Because what they did then was look at oral and intramuscular injections of vitamin D. And based on 3 studies, they said that intramuscular injections are actually better after malabsorption procedures. But 3 studies, an RCT for duodenal switch, observational through my gastric bypass, and then the BPD. And that's expert opinion, but that's a strong recommendation. And in the UK, clinically, that's got huge implications if we start giving people after gastric bypass IM vitamin D injections. So I think got to be very careful when you're looking at the evidence and how it's being used. Then in the UK as well, we've just recently, the National Institute of Clinical Excellence has actually reviewed the evidence base for vitamin B12. And that was really important to me because in the UK we have intramuscular injections, and that's the common practice. What they also looked at, do we measure active B12 or do we measure total B12? They acknowledge that active B12 is a better measurement, but in the UK it's expensive. So in clinical practice, the chances are we won't do it unless we've got concerns. They also looked at the reference range, and I've known from Manisha Sharma, a chemical pathologist in the UK, her real concerns about when vitamin B12 is at the lower end of the range because it's not specific enough to pick up vitamin B12 deficiency. And in the new NICE guidelines, they look at that and they actually say if the range is this, the person may have vitamin B12 deficiency. So then when I look at studies, some of the studies are reporting that what they are doing helps prevent vitamin B12 deficiency, but actually some of those levels are actually in that indeterminate range, so they may have B12 deficiency. Also, I wasn't aware that people of a black origin need a higher reference range than people of white or an Asian origin. So that's got implications to practice, but NICE don't actually say what that reference range should be. And then they looked at oral and intramuscular. And they said the evidence base for the oral wasn't great, but if we're going to give oral, we should be giving at least, I think it's 1 milligram a day. I might have that wrong, I need to go back and check. But when I looked also for the evidence base for sublingual and nasal, I couldn't find it when we were doing our guidelines. So where has that come from, and has it been done in people having bariatric surgery? Fat-soluble vitamins, another one. Often they're not measured, And maybe for some procedures, such as the rheumatoid gastric bypass, the sleeve, we don't need to measure them routinely, mainly if we've got a concern. But if we're looking at a duodenal switch, one anastomosis gastric bypass with the long pancreatic limb, the SADIS, we should be measuring them, but often they're not. And also, can you measure them? And then often, zinc, copper and selenium are not measured, so we tend to rely quite heavily on case reports. If they are measured, it's very short term, where the fat-soluble vitamin and trace mineral deficiencies come on over years. And then, if you are doing these procedures, can you actually get hold of the fat-soluble vitamins that the patients need? And if you do, how do you treat the deficiencies when they arise? I just want to highlight this recent paper that came out, which actually looked at guidelines and actually assessed them. And they made some pointers about what to look at. So I would definitely recommend that you look at it, because I think you should all be thinking about whether your country needs its guidelines, making sure you've got the right stakeholder involvement. They really emphasise the importance of having allied health professionals in that guideline development, and patients, which we always do in the UK. Making sure the recommendations are clear, making sure that you look at the barriers and facilities to implementation, and actually making sure that those recommendations are really good for clinical practice. So, when you're looking at guidelines, don't just pick them off the shelf. Consider, do they meet the needs of your service and your population? I'm bad at this, but we all should be contributing to the evidence base, even if it's a case report. It's really important. And if we don't make the case for guidelines, we can't make the case for long-term care and follow-up. And then just a shout out, because our BOMS nutritional guidelines in this systematic review were classed as one of the second best bariatric guidelines. And we had a very multi-professional team. So thank you for your time, because we're about to review these again, and it's going to take some time. Thank you.
Mary, for a wonderful overview there. It's so interesting how the different effects in our different countries all across the globe, and not a lot of evidence in Australia, we do note as well. So I'd like to welcome up Violetta Moyes, who is going to speak to us. We have met Violetta yesterday. I think a lot of you would know Violetta, so we're looking forward to hearing from you. Thank you.
Thank you very much. I am happy to be here, and thank you for the opportunity. So, well, they give me a very, very challenging title, right? Talk about the fact or fiction about changes, eating healthier changes induced by bariatric surgery. So no conflicts, but, we know that changes in eating behavior exist after bariatric surgery. And we are already familiar with all the gastrointestinal peptides that occur and lead to decrease hunger and increase satiety. And also we know that there is, because anatomical changes, a decrease in the ingested volume that leads to a decrease, also a reduction in total calorie intake. So the changes has been shown to appear to food preferences, also to macronutrient distributions, food selection, and also food appreciation. So the hedonic component, which is comprised by the sensory, the liking, right, the pleasure, the sensory properties of food, and the reward system that talks more about motivation to eat, the implicit or the explicit one, right? The conscious of the motivations are also changed after bariatric surgery. But there are many other determinants of food intake: the biological component, economic, physical, social, psychological, the attitudes that they have, and also the perceived and experienced stigma that people living with obesity encounter around over life, right? So we accept that the food choice is a process and is impacted by a lot of components and dimensions of our life. This is a model that I found very interesting because it is letting us to help us understand that the life course exhibits of experiences is also conditioning whatever food we choose to take. And these had their own influences, and also some personal food systems are going to be dragging the decision that we are going to finally make. And we also have to consider this after bariatric surgery for sure. And this is also impacting on the food behaviors that is completed or comprised for many skills that will help us to decide and make and do the action of what to eat. And if you remember the hierarchy of human needs that builds on one another, the Maslow theoretical theory, the Maslow's theory of needs that I'm sure we are all familiar with is, well, food, water, and also other components of the lifestyle medicine are the base on this and cannot be ignored. But going back to the changes that were observed after bariatric surgery, well, we know that meal size is changed, is altered after the procedure, and also the eating rate. So especially 6 months after surgery, when the most restrained period exists, so the change is more evident. But then over time, all the components that were measured tends to normalize. So meal size decreased, but is also increasing a little bit, and this study was done up to 2 years. The same happened with eating behaviors following, in this case, gastric bypass. The cognitive restraint, of course, right after the procedure during the honeymoon period is increased, but then is going back to almost normal close and up to the 2 years after the bariatric surgery. And also the uncontrolled eating and the emotional eating, they all follow a similar pattern. And also, we know that it was a shift in the food preference in this cohort, in this study, that was done by indirect measures, so questionnaires, and we already know what that means. So it had implicated many errors that we cannot control, and is a very well-known limitation in nutritional studies. So, people tend to eat better, change the preferences, decreasing the sweet and the fatty foods, and increasing the more healthier. But this was done also in a short time, up to 39 months after the procedure. And also there are a decrease in the hedonic component, as you can see in the dimensions measured in the other part of the slides. And these preferences have also been shown to change post-operatively, and depending on the perceived modification. So people tend to score their preference for food in the A figure you will see, and if you see the B figure is showing the changes as perceived taste or changed taste, or the liking and the wanting system rewards that they had in that particular moment. So the changes were, as you can see, decreasing this preference for, again, fats and sweet foods, but this was done depending on the duration of the follow-up of the individual sensory perceptions, and also on the weight loss outcomes. So it's not for everyone the same. It's different depending on the situation of everyone. And this is something that we keep listening, because we are understanding that this is not obese population, this is obesities. So there are as many as people in the world, and this is kind of exciting for us as it's a challenging of management. So as this other systematic review and meta-analysis showed that, in fact, preferences modification exists after surgery in terms of macronutrients composition of the diet. This was done up to 2 years of follow-ups, and as you can see, the proteins increase a little bit but tend to decrease. Also, carbohydrates remain almost unchanged, and lipids tends to decrease right after surgery, and was increasing up to these 2 years. So there is they saw that the macronutrient component changed up to 2 years after surgery. But previous studies of our group, actually that was part of my dissertation back in 2013, we follow 355 patients. We wanted to learn and know how were they behaving, and we saw that in fact the macronutrient components at long terms tend to be similar to baseline. Of course, calorie intake decreased right after surgery and was slowly increasing up to 5 years follow-up. Actually, we have data of 10 years follow-up, and it's showing the similar results that you see at 5-year follow-up. So macronutrients maintain stable over time. This was done also, our studies, with some indirect measures. We all want direct measurements, right? So this group of leading by Carol LaRue did this study that we all wanted to know, to learn from, right? Which is let's put our patients in a buffet and let's see how they behave. Well, when the calorie intake was decreasing over time, it seems that was related more with the portion size consumed that was smaller rather than different selection of food. As you can see, they didn't change over time. And thank you. And they were interested to know the factors associated with these different situations, and all these that are listed here that I am not going to speak about are too many different dimensions, and all of them were explaining the majority of these differences in choices. Recently, last week ago, when this study was published, showing that bariatric surgery reduced the sweet unliking by reduced sugar intake. I am adding this here. It was last minute added because we know that this is another direct measurement, and we are interested in that quality of measurements. And we can wonder what are the clinical relevance of these food preferences change. We have a randomized control trial that suggests, and that's randomized control trial and meta-analysis and systematic review that suggests that that calorie intake is not associated with weight loss, and we are missing more studies that shows that the effect of a healthy diet on the metabolism, right? Like the beneficial effect of the diet independent of weight loss. And when I say that, I remember it comes to my mind the Mediterranean diet. In a review of the Mediterranean diet, we couldn't observe like the following: this Mediterranean diet after bariatric surgery can influence weight loss and resolution of comorbidities. And this was done even with this limited literature. So we know that bariatric surgery does not affect food preference, but the same author of the buffet study showed that individual changes may predict weight loss. Why say that? Well, again, to show that diversity is very powerful. But also, and these are the components that have been shown to be interacted with food choices. And because this is very individual, we want to learn more about qualitative studies. So from this study of Lisa Tolvanen, we know that patients experience all these situations, they feel overwhelming by the dietary changes that are proposed after surgery and during the whole process. And we were talking about this yesterday. So they refer to have a lack of nutritional knowledge, emotional eating, or disorganized eating patterns. So at this point, I am finishing now. This is my last slide. This is the food choose model that we were previously talking. And if we do bigger this component, this part of the pyramid related with food behaviors, well, you see there are a lot of things that we can do to help our patients to improve these food behaviors. We can work with them to better prepare and eat like skills that we could give them to help control more all these dimensions, like with culinary medicine. Again, this is a complex network. All of this needs to be done: education, co-creation of interventions, developing always the stigma-free environment to work with this, do support groups to talk about this, help to develop new skills and motivate for a better lifestyle. So answering, I can say that from my perspective that metabolic and bariatric surgery results in a healthier food preference. Well, that is more than a fiction right now. For many things, the indirect measures of eating behavior in both human and rodent suggest that there is some changes, but it's always a short term, and is not taking into account all these many influences of the dietary intake that we were talking about. So the fact is that we have the opportunity to influence on their choices that they make and focus on healthy dietary pattern instead of weight loss or calorie intake for life, and do this along with lifestyle medicine components that we have to do over time. And of course, I am inviting all of you, it would be amazing having you in Venice for the European chapter IFSO Congress that is going to happen in May. Thank you very much. I'm sorry.
Thank you. Thank you very much, Violetta, for a fantastic presentation. If those of you at the back are wanting to have a seat, there are a few at the front if you want to walk through now. In the meantime, I'd like to invite Anne-Marie Hindle to the stage to come to talk about eating behaviour and weight outcomes in metabolic bariatric surgery. Thank you, Anne-Marie.
Thank you. Before I start, I would like to thank Dr. Eva Conceição. She was invited here to give a talk on this topic, but was unfortunately unable to come to Australia, but she has generously provided me with information to include in this presentation, so thank you. I have no conflict of interest to report. So, when we think about eating behaviours after surgery, we've probably heard about a lot of different ones, a lot of descriptors, a lot of things that in studies have been related to weight outcomes and psychosocial outcomes. However, there appears to be, in the latest research, a common denominator that describes or that predicts weight loss or is related to weight loss, and that is loss of control over eating. Regardless of what type of eating behaviour, it's that experience of loss of control that people report. And loss of control is this sense that somebody has that they can't stop an eating episode from starting, and or they can't stop once they've started. So they're feeling out of control. We can think about overeating as this dimensional behaviour for which loss of control increases as we go up this arrow, if you like. So this comes from work from Conceição and colleagues, and they've described the homeostatic eating, moving to the passive overeating, that non-compulsive, unplanned grazing experience, then that more compulsive, which the inability to sort of resist that, it's like a picking and nibbling and unplanned eating. We've got the subjective binge eating that you might have heard of, which is where a person feels like they've experienced a binge episode and they're experiencing loss of control, but perhaps the amount that they're eating is not a substantially large amount or a really significantly large amount. And then we have what we call the objective binge episode, which the amount of food is a significantly large amount for those circumstances. And in this study, they looked at the degree of loss of control. And this is the mean and standard deviation. And so you can see as we go across this dimension, patients' rating of loss of control increases. But it's not just weight that this impacts. When we look at emotional eating, as we go across this dimensional eating behaviour, again, predominantly, patients' reports of emotional eating increase. And for psychosocial outcomes, depressive symptoms also increase as we go across this dimension of overeating. So this graph here, the little one in the top, has the first point in it as pre-surgery along the x-axis, and we can see that loss of control, reports from patients of loss of control, decrease substantially after surgery, from pre to after surgery. And the larger graph shows you that across time after surgery, people report that that loss of control increases. So it doesn't go back to pre-surgery levels, but it does increase. And you can see that that increase sort of peaks at sort of 2 years across to 4 years. And this is important for us to know because these eating behaviours, some people call them problematic eating behaviours in the research, non-normative eating behaviours, they appear early, but the results or the impact of them don't happen until a bit later on. This is a study by Devlin and colleagues in 2018, and they looked at the impact of loss of control on weight outcomes. And the first was the percentage of total weight loss, and they measured using the eating disorder examination interview, which is a clinical interview with the bariatric surgery version. And they found that for every 1 unit increase in the eating disorder examination global score, patients experienced 4.1% less total weight loss. But when they drilled down and they had a look at the loss of control component, you can see that that effect size is larger. So patients reported less weight loss, so 6.2%. They also measured weight regain, so this was the percentage of regain of the maximal weight loss that they had experienced. Again, the global score on the eating disorder examination, the measure of eating disorder psychopathology, for every 1 unit increase, there was an 8.2% increase in weight regain. But when we have a look at the loss of control part of this, you can see the effect size is significantly greater. So patients who, for every 1 unit increase of loss of control experience, regardless of what that eating was, the regain was 20% of maximal weight loss. And in this study, when they looked at other eating behaviours that didn't have a loss of control, they found that they weren't related to weight change. This is another study that's looked at banned patients and bypass patients, and you can see that light grey line. That's the trajectory of people experience what they called in this study problematic eating behaviours, which was mainly around loss of control. And you can see the effect starts to impact around that sort of 18 to 24 month period in both types of operations. I don't just want to talk about weight loss though, I also want to talk about psychosocial outcomes. Eating behaviours have shown a relationship to psychosocial outcomes as well, particularly that loss of control. And as we saw earlier, it's related to increasing depression, increasing emotional eating. So there are a lot of other impacts that we want to be looking out for, except in addition to weight loss. So again, post-surgery loss of control eating and binge eating of that sort of sub-threshold presentation of that low frequency or limited duration had a significant impact on health-related quality of life. So the higher the loss of control, the more common the binge eating experience, the less health-related quality of life the person experienced. So, what can we do about it? Disordered eating behaviours or non-normative eating behaviours, they can appear early after surgery with the impacts felt later on. It's really important that we treat eating disorders prior to surgery. However, treating an eating disorder prior to surgery, it actually doesn't show a relationship in the research to the development of eating disorders after surgery. However, treating eating disorders before surgery is so important because it gives the person a sense of self-efficacy, it helps them recognise disordered eating or problematic eating behaviours after surgery so that they can engage and get assistance earlier. It gives them a sense of hope that something can be done. In addition to treating an eating disorder, we also want to be doing a lot of psychoeducation as well. Patients are an active agent in the treatment process. We want to tell them the changes to expect, the types of eating behaviours that might trip them up, the things that they might experience that they want to reach out for help for. and the importance of their support systems, their social, their family, and their healthcare support systems. Post-surgery, consistent, regular screening for challenging eating behaviours, particularly the loss of control element. As integrated health practitioners, as allied health practitioners, we probably see patients a little bit more often after surgery, and so it's important for us to ask those questions, not just about eating behaviours per se, but probing a little more just to see if patients are experiencing that sense of loss of control. Because there is a lot of shame that often goes with that, and so asking those questions in an empathetic manner and asking them is going to be really important. Then we can offer like a stepped care approach. So the first approach to that might be psychoeducation and self-help. So for people who aren't exhibiting any sort of sense of loss of control or any non-normative eating behaviours, just giving them information can be really helpful. And we want to match our intervention to the level of presenting issue. So then we might help with some sort of guided self-help where we give them self-help materials and they might come in for short sessions with a healthcare practitioner just to help them work through those. Some people might need individual therapy or group therapy, very specific eating disorder treatment, and there's also sort of outpatient or inpatient types of care that we can provide as well. So thank you very much. Please feel free to reach out if you'd like more information.
Thank you so much, Anne-Marie. That's fantastic. And another reminder, following on from yesterday's encouragement for health professionals to be asking those questions in all of our follow-up appointments. So I'd like to now welcome Daniela De Benedetto, who's a dietitian from Melbourne. She's going to give us a dietitian's perspective on management of reactive hypoglycemia. Welcome, Danny.
Thank you, and thank you for the invite. I'm so excited to be here. I've only just started my PhD. Well, I feel like I've only just started, but I'm a couple of years in, and I'm really excited to share this with you. It's an area of research that I guess is not perfectly researched yet, and there could be some controversy in some of the things that I say, but I look forward to hearing the feedback and comments afterwards. So my PhD topic is the prevalence and implications for the management of postprandial hyperinsulinic hypoglycemia, which I'm sure you'll appreciate me calling PHH throughout the presentation, in the metabolic bariatric surgery population. And I've got no conflicts of interest. This is going to be my legacy, if I get this right. This could be my legacy. Up until papers written in 2023, they're still using late dumping syndrome and PHH interchangeably, and I truly believe that they're not interchangeable, and I hope today that I can convince you that they're not interchangeable. So PHH is a condition where you get a significant spike in insulin postprandially that leads to a clinically significant hypoglycemia, and it depends on which paper you read, but that level of hypoglycemia could be around 2.8 to 3.3. It emerges usually at least a year up to 8 years post-operative, and normally in the Roux-en-Y gastric bypass population. It's otherwise known as reactive hypoglycemia. This one's for you, Michael Talbot, just in case you're here. Pancreatigenous hyperinsulinic hypoglycemia. Of course, that's a Michael Talbot thing. Or post-bariatric hypoglycemia. It's different from fasting hypoglycemia. I guess we hear the terms hypoglycemia, we think diabetes. It's different from fasting hypoglycemia because in this population, our patients, or this population, they're actually getting the hypoglycemia after a meal. It typically occurs between 1 and 3 hours postprandially, so you can see here how there's a bit of overlap with late dumping syndrome. But the unique thing to PHH is that this cohort of patients get neuroglycopenic symptoms as well as the autonomic symptoms. So there's a distinct postprandial pattern. You get quite a sharp rise in glycemic, in blood sugar levels. Usually it peaks at around 30 minutes, and then you get a rapid decline, which leads to the hypoglycemia. So these are some of the symptoms that can be quite concerning with relating to PHH, and certainly some of these are interchangeable with late dumping syndrome. So the adrenergic and cholinergic symptoms such as sweating and tremors and palpitations and hunger and those kind of things. But then you go that step further, and this is where it becomes PHH. You get the weakness, you get the altered mental state, possible seizures and comas because your blood sugar levels have dropped quite significantly. The other scary thing about PHH that doesn't tend to happen with late dumping syndrome is hypoglycemic unawareness. So this population will have hypoglycemic events so frequently that they start to develop an adaptation to those hypoglycemic effects, and then they have to have an even lower blood sugar level before they start to recognise that they're having a hypo. So although it's still a little bit slow in coming round, in 2017 the ASMBS guidelines did do a systematic review and did put out a position statement on PHH, and they said that it should be suspected when postprandial neuroglycopenic symptoms occur after bariatric surgery. There are two quite great landmark studies that look at the pathophysiology of PHH, but I'm going to leave this to my colleague, Dr. Christine, who will do a great presentation on that. Physical alterations of the digestive system, changes in intestinal hormones, particularly the incretins, excessive postprandial insulin response, and a reduction in the clearance of that insulin. And this is the one that's more kind of coming into the research now, the impaired counter-regulatory hormonal response. Another study looked at the increased incretin levels, restoration of beta cell sensitivity to GLP-1. So what we'll find in a moment, one of the risk factors for having PHH after bariatric surgery, particularly Roux-en-Y, is having impaired glucose tolerance or insulin resistance prior to surgery. And that what they're thinking is that hypertrophy of the beta cells of the pancreas, that doesn't respond quick enough after the weight loss in such a short space of time. So if you've got gradual weight loss, the cells will atrophy, and the insulin won't be released quite as, in such a high concentration. But with our patient group, the weight loss is quite rapid and the pancreatic cells can't respond quick enough, and you still get that hyperinsulinemia. So an increased tissues, insulin sensitivity, abnormal response to the counter-regulatory hormones. So this diagram here just looks at the hormonal thresholds relating to blood sugar levels. At a blood sugar level of around 4.5, you get some suppression in endogenous insulin, and then you get at about 3.8 millimoles, you get, I think that's about 50 or 55 of the other type for those who are from other countries. The counter-regulatory hormones at 3.8 start to kick in, the glucagon, the adrenaline, to try and raise your blood sugar levels again. However, you've got other issues. Symptomatic thresholds include at 3.2 millimoles, you get autonomic symptoms. At 2.7 to 1.5 millimoles of blood sugar level, you get severe neuroglycopenia. And it can even get as bad as having cognitive dysfunction and cardiac arrhythmia. So this is something we really want to try and avoid in our population because it can actually become quite dangerous. So as I mentioned before, hypoglycemic unawareness is another problem. It can occur because of such frequent hypoglycemia. You develop an adaptation to that, and then you need a lower blood sugar level to actually get the autonomic or the symptoms, the hormonal or systematic symptoms, I'll get there eventually, to actually have an awareness of the hypoglycemia. And in this case, it can go either way. When someone recognises they've got a hypoglycemic unawareness, and they can either have a fear of eating, because, if they, or fear of eating too much, because if they eat too much, they'll have a rebound effect. And if they eat, they'll still get a hypoglycemia. So, either way, which then leads to malnutrition and and all kinds of adverse effects. So with hypoglycemia, unawareness associated with PHH, normally in hypoglycemia you get a decrease in insulin secretion, but that counter-regulatory response is hindered. You get an increase in, which ends up leading to hyperinsulinemia. You get an increase in glucagon secretion. Normally with hypoglycemia, that counter-regulatory response isn't working, so you get a suppression of glucagon, and you get an increase, reduced glycolysis. You get, normally with hypoglycemia, an increase in catecholamine release. In this case, you get a suppression of that, which leads to persistent hypoglycemia, a loss of counter-regulation and recurrent hypoglycemia. So this is, how does late dumping and PHH differ? Well, you've got the early dumping, which we know is more of a gastrointestinal issue. You get that osmotic effect with certain foods, whereas PHH works or tends to be a problem 1 to 3 hours after surgery instead of 20 to 30 minutes. But it's more related to late dumping syndrome, and the differences really here are that late dumping syndrome doesn't lead to a risk of neuroglycopenia, and this type of hypoglycemia can actually occur overnight when you haven't eaten at all. So the risk factors: female gender, getting the surgery at a younger age, non-diabetic before surgery, a lower HbA1c before surgery, and greater weight loss in a shorter period of time. So from an assessment point of view, there's no validated questionnaires, there's no best practice guidelines other than the 2017 ASMBS that probably need to be reviewed. There's no pathway to predict developing PHH other than those risk factors that have been identified, and no classification of severity. From a diagnosis point of view, there's no real diagnosis either. Oral glucose tolerance test probably isn't a good idea, because if you want to make them feel pretty terrible, that's probably going to do it for you. But a mixed meal tolerance test and continuous glucose monitoring are usually the things that are used most. Continuous glucose monitoring, however, is less accurate in the hypoglycemic range, and we need to keep in mind that it tends to identify interstitial glucose levels rather than blood capillary glucose levels. And from a treatment point of view, diabetes treatment and PHH treatment is different, but also very much the same. The most recent research in 2017 indicates that there's a 10-point nutrition plan where we want to have low glycemic index carbohydrates, we want to have small frequent meals throughout the day, we want to avoid alcohol, we want to avoid drinking with meals. But I want you to remember one thing that's unique with PHH is that insulin is an anabolic hormone. So whether you have carbohydrate, whether you have fats, whether you have protein, it's all going to be released. And some patients can actually get PHH from having meat-based products. The other treatment is inserting a PEG tube into the remnant stomach so that the nutrients go back through into the digestive system proper, and therefore you'll find that PHH will settle quite significantly. So in conclusion, I guess my take-home message is it's not dumping, it's PHH. Watch out for it. And some of the symptoms are different to dumping, and also look out for protein and fat-based foods when doing a diet history to determine whether PHH is occurring.
Before the next presenter, it's my honor to give Daniela the award of Dietetic Research Prize from the Bariatric Surgery Interest Group. Congratulations.
Thank you, Daniela, for a fantastic presentation. And
a surprise. It was a surprise.
That's amazing. I'd like to invite Christine Steer to give us the surgeon's perspective. So thank you and welcome.
Ladies,
and gentlemen, of course. Thank you very much for having me. And it's my great honor, and I corresponded with Daniela before, and I want to show you the surgeon's perspective and a little bit more of the physiology. This is my conflict of interest statement. You see it's just about endoscopy, has nothing to do with this presentation. And what I want to show you is late damping, as Daniela said, is the common expression on that, but it's more PHH. Or post-bariatric hypoglycemia. And if you look at the next lines, you will see that the incidence is under oral provocation up to 75%. And if you know that exactly 25% of the patients have a preoperative diabetes, and you add 75 to 25, you see this is all the population we do operations on. So what you have to know is that the hormonal regulation, the incretins, the hormonal regulation of digestion in the small intestine together, and in the context of the anatomical variation and modification of a bypass procedure, the duodenal exclusions lead to a modification in glucose metabolism, and we know this since long. As Walter Porteous wrote in 1995, who would have thought it? We do think about it. But nowadays, even the Joslin Institute in Boston says that glucose metabolism after bariatric surgery has to do or deals with diabetes remission, but as much with hypoglycemia, and I want to show you why. So the natural anatomy before operation, we know that gastric accommodation is a very, very important thing to create fullness, to create satiety, and this is very much depending on the speed of gastric emptying. And if you keep in mind, damping means a very quickly emptying. So this gastric emptying is determined or governed by the pylorus, of course, but there is duodenal feedback, and it's transferred to the brain via the vagal nerve. And if you look at this picture, you see the vagal nerve really embraces the stomach. So what is the hormone regulation? The hormone regulation is very simple. In the normal anatomy, it begins in the duodenum with the output of CHIP, glucose-dependent insulinotropic protein that induces the oral carbohydrate digestion. It begins with CHIP and it ends at the end of the small bowel with the output of GLP-1. GLP-1 terminates the carbohydrate digestion. So what do we do when we do a bypass? We modify that. So we have early damping, late damping, as Daniela already said. We can't jump over that. But what we do is we take away this government of the pylorus and we make a pouch jejunostomy. And this means that there is no discrimination between pouch and small intestine, and that this alimentary limb together with the pouch reacts like one system, and there is no difference in the intraluminal pressure between the pouch and the alimentary limb. And this is by definition already damping. So, but when we then look at the hormonal regulation, you see that the CHIP output indeed is suspended because there is no passage through the duodenum. So we have a high output after that in GLP-1. As in this extreme catabolism, of course, there is an unspecific uptake of glucose in the alimentary limb. So you have a high or an elevated glucose level that meets the GLP-1 output, which is massive and leads to a massive insulin output. And this is what I call a biphasic insulin output after Roux-en-Y gastric bypass. First, insulin is diminished because it's non-incretinuric output in the upper segment, and then there is a massive output. And of course, maybe there's another influence on the pancreatic enzymes, and you see that the US physiologists, pancreatic physiologists already think about this intrapancreatic relation. Maybe amylase has also to do with that because there's a so-called halo effect, and if there's a reabsorption of amylase or breakdown particle of amylase, this will also lead to a lower insulin output in the upper segment. Can you see that? Yes, you can see that. If you do continuous glucose monitoring, you see this swing, this steam, what Daniela already said, the steam increase in glucose, and then the quick diminish of glucose. You can see that in patients that had no diabetes before, and if you take those two pictures together, you see there is simply the level of glucose is different between patients that had diabetes before the bypass surgery and had no diabetes. In patients that had no diabetes before bypass surgery, the glucose level is simply lower than in those that had diabetes. Those that had diabetes go to remissions. Those that don't had diabetes before may have a hypoglycemia. Can we measure that? Yes, we can measure that. This is from a Brazilian group that showed that GLP-1 is extremely increasing after bypass surgery, especially after 30 minutes, after the passage through the alimentary lymph, arriving in the common channel. But what we have to do, I should tell you the surgeon's perspective. What I do is to take the patient's history. I do a score because this is then officially diagnosed. I do continuous glucose monitoring, as I showed you. And of course, I do an endoscopy because I'm an endoluminal surgeon. These are the two scores we have. It's the validated Six-Stat score, and it's the new ART score, which is pretty much the same. I showed you the continuous measurements. I, of course, do upper endoscopy, and you can see that the pouch and the alimentary lymph is one system because the anastomosis is really enlarging over time with the motility of the GI tract. And there are two applicable endoluminal suturing systems, which I use both. The one is the overstitch system. The other one is the incisionless operating platform. And this is what I do. I really try to tighten the outlet again so that the pouch emptying decreases, the speed of pouch emptying decreases again. And this is what I do. This looks very tight, but this is adapting over time. You see on the right side the outlet after 4 weeks and after 3 months. And this is the other system where you only can do single sutures to tighten the outlet is another thread, but works both very well. And I want to show you, because I measured the first patients of ours in a trial, and you see I divided it, as Daniela said before, in patients according to the Whipple trials that really had a PHH and went down lower than 2.5 millimoles, and compare that to the other patients that don't went that deep in the glucose level. And you see that really also in this cohort, the weight loss is a significant predictor of damping patients who lose extremely weight, who are, I would say, are extremely catabolic. This is very different. Catabolism is the metabolic status, not the weight loss. It's the catabolism. And those patients also have a very low HOMA index, and they have no history of diabetes at all. And if you look at that, these are the graphs of the OGTT. And you can see that there is really, in patients that damp, there is really a massive insulin output. It's the blue dotted lines versus the red dotted lines. These are the patients that do not fall down under 45 milligrams. And as I said, we measured that. You can see that with the endoluminal intervention, there is a very good outcome, and the patients go down with the six-shot score to normal ranges. After that, they also lost weight. They have no pain. We did a pain scale on that. They have no inflammation. We published that together with the Mayo Group. My take home for you is that endoluminal endoscopic re-intervention in patients with PHH, first of all, in contrary to laparoscopic surgery, preserves the bariatric anatomy. You need a stomach to feel fullness and satiety. That the endoscopic interventions are minimal invasive, and then they can be applied in an escalating treatment algorithm. The next step could be a laparoscopic approach, and you will see that there is much more to come on that topic. Thank you very much.
Thank you very much, Christine. That was a wonderful presentation. Thank you. Please take a seat. Just like to welcome to the podium now Dr. Lee Kaplan, Associate Professor Lee Kaplan. Here he is. Needs no introductions after already a wonderful presentation this morning. Thank you, Dr. Kaplan.
Thank you very much. It's a pleasure to be here. This must be the most popular place in the whole building right now. I couldn't get in because they told me it was full. Okie doke. So I was asked to talk about the microbiota and something that my laboratory has been working on for many, many years. I'd like to be able to tell you, just in case somebody has to rush to lunch here, that we have the solution. We don't. But let me go through what we do know. So just to level set everybody, the microbiota, which is what we call the bugs, and as opposed to the microbiome, which is what we call the DNA and RNA in the bugs, is composed primarily of bacteria, viruses, archaea, which is an organism that is older than the bacteria, and fungi. We focus primarily on the archaea and the bacteria because that's really where all the work has been done. But we shouldn't lose sight of the fact that everything I'm going to talk about is going to be bacteria and archaea. But viruses and fungi are as important a part of the microbiota as anything else. We just don't know as much about it. Historically, we thought of it as just outsiders coming in, but these bugs don't live anywhere but in our guts. They don't live, or maybe in other parts of our body. They can't live in the real world effectively. They live primarily inside us. They live together. They don't tend to live by themselves, and they don't typically find their way outside and in the same form. They might mutate or somewhere, or they might live in different colonies outside. There's a lot more information genetically, and I think something that's worth noting is that if you look at evolution, these bugs are usually, the bacteria anyway, are usually reproducing about once a day. Now in culture, E. coli will reproduce once every 20 minutes, but they're slower. They're, as I say, they're in a population, and they're sort of in a community of different bugs. But even once a day means that the amount of evolution that these bugs can undergo over the course of a human life of 80 years is the equivalent of the amount of evolution that we can undergo through our own DNA in about 10,000 years. And so the idea that when we say, genetics don't play as much of a role in obesity because obesity, genetics haven't changed and they can't account for the modern epidemic of obesity. Actually, the bug's genetics can change enough to account for the modern epidemic of obesity, even though the caveat there is that the bugs probably are under new selective pressure because of what we're eating and what we're exposed to. So it still ends up being the environment, because the environment now can influence the genetics of the bugs during the course of a human lifetime, even though even though our own genetics, of course, would take thousands of years. So what does that all mean? Well, again, we first thought that these bugs were foreigners that were invading us. They're not. There's no human that's ever been born without these bugs, some group of bugs. In addition, we then started thinking, well, it was an organ inside, and you see this thing, we considered an organ inside the human gut, just like the liver or just like the kidneys or something else, where it's always there, it has signaling capacity. But more than an organ, because it's in a funny place, it's a signaling system. And what it does sitting in the gut is it transmits information from outside the gut to the rest of the body, and transmits information from the rest of the body into the gut to influence itself. So what you're talking about is really a very, very elaborate messaging system inside the human body that has unique characteristics because it's got all these weird organisms in it, and it can mutate very quickly. And the microbiota changes. It's first transmitted from the mother to the babies. And it's done that both during pregnancy, but for the most part during birth, and then during breastfeeding thereafter. And then from there, the baby's microbiota starts to change quite rapidly in response to different kinds of foods that they're eating, starting with breast milk and then moving on. And then around age 3, the microbiota stabilizes. And once the microbiota stabilizes, it doesn't really change a great deal. Of course, it changes in response to the environment, but not to the degree that it's changing during these first 3 years. So when we think about the development of a human being, we think that things happen in utero, and then when you're born, there's a fundamental shift in the way all the body works. And so things are less flexible after you're born in terms of development. And then we think of puberty as being the next big event where things become less flexible again. And then, of course, as we age, particularly menopause in women, it becomes less flexible again. So that your flexibility, your ability to adapt to the environment is coming down and then drops down at birth, drops down at puberty, drops down at menopause. But the whole time it's sort of decreasing. But what I just said was there's a fourth time, which is at the time when the microbiota stabilizes. So we have to throw that one in there around age 2 to 3, when the microbiota stabilizes, that you have a fourth sudden drop in the plasticity or the flexibility of the human body. Now, the first studies about 20 odd years ago showed that the bacterial signature in people, in animals with obesity and in people with obesity, was quite different. And the interesting thing about these experiments that are shown here is that it didn't matter what kind of obesity. If you had obesity from genetic obesity, like DB mice or people with genetic defects that cause obesity, or you had obesity from eating a different diet or just whatever garden variety obesity from the clinic, you saw these same signature patterns. And interestingly enough, if you see the same signature patterns with all the different kinds of obesity, it makes you think maybe the obesity is causing the signature patterns rather than the signature patterns causing the obesity, because the original cause of the obesity is different in all of these different model systems and in different populations. Well, it turns out it worked both directions. And if you transfer the microbiota from an animal or even a person that has obesity to somebody without it, you do see a change in metabolic behavior of the individual to a certain degree. And those observations were what fueled the whole idea that the microbiota are important for metabolic disease. So the first study showed this, but when you start to look in a more sophisticated way, those first observations were not really reproducible across the population, because it turns out that the microbiota is so complex that those simple things, you may have heard of firmicutes, Bacteroidetes, these are different types of bacteria. The firmicutes, if you remember F for firmicutes, if you have more firmicutes, it's related to fat, so F and F. So whereas because everybody forgets which one, I always forget which one. But it turns out that it's much more complex than that. No surprise there, right? There's lots of different ways of developing obesity. There's lots of different pathways. There's lots of different genetics behind different types of obesity in different people. But the general pattern, though, is that when you transfer the microbiota from an animal that has obesity to an animal that doesn't, they gain weight. And from an animal that's lean to an animal that has obesity, they gain weight. And this has been done in animals, in mice, that, unlike humans, are designed to have no microbiota. So they're born with no microbiota, they live in a sterile environment, then we give them microbiota, and then the microbiota we give them is the only microbiota they've ever been exposed to, so may not be as rich as our microbiota, but it is the only thing they've got. And when you do these experiments, you can transfer obesity or thinness from one animal to another. Now, it turns out if you take the microbiota from a human being that has obesity, OBS, or used to have obesity, has obesity, but is now controlled with Roux-Y gastric bypass or sleeve gastrectomy, what you find is that when you transfer that microbiota into a germ-free mouse, a mouse that doesn't have a microbiota to start with, you see transfer of the information from the human that had either thinness or obesity to the mouse, and you can change the mouse's metabolic behavior and the mouse's fat mass. But in the clinic, we have never been able to reproduce that. And that's the question, is why can't we reproduce it in the clinic? And since time is short, I'm just going to show you, this is a meta-analysis showing that it didn't do anything. You notice everything's right close to the line there. So there's really very little effect of the microbiota on body fat, on metabolic function like diabetes and the like. So where are we in the clinic today? Well, people will say, the pros are, there are very few safety issues with either probiotics or microbiota themselves. There may be some benefits, even though we haven't been able to detect them in controlled studies. And as I mentioned, the weight effects have been small. The cons are that we may not be doing it right. We may not have the right bugs. The bugs change when we put them into somebody else anyway. And are we really thinking through this? Maybe we should be thinking about prebiotics and probiotics. What we do is we change the native microbiota. So most probiotic species are not native to the human intestine. As I mentioned, our bugs inside won't live in the street, and the ones in the street won't live inside us. So the idea that we can go make bugs in a laboratory and put them into people and have them even live there, much less do anything, is probably a little bit far-fetched. And of course, we don't know how well they engraft. In fact, they don't engraft very well. So where we are is that we have a few reports. One report back from 2012 showed improved insulin sensitivity, but no change in any other metabolic outcomes. Unfortunately, this has never been reproduced, even by the group that produced it in the first place. So that's a bit challenging. If we look at two studies done in Boston, which is where I spent most of my career, what you see is both of these studies had issues. Neither of the studies changed anything. They didn't change insulin resistance, they didn't change hemoglobin A1C, they didn't change weight. And so clearly we are missing something. And I think the thing we're missing, and this is really where I want to close, I think the thing that we're missing is the fact that the microbiota aren't the cause of anything. They're just a reflection of what we eat, what toxins we may be exposed to. It doesn't have to be even what we eat. We don't have to eat them. We could even breathe them in, and they'll eventually find their way to the gut. The drugs we take, if you take various drugs, and those drugs can be injectable, and they'll still change the microbiota. There's communication back and forth. And I think we know too little to be able to harness microbiota for diseases like this. So where we are and where do we think about for the future? Well, right now, there's only one group of diseases that are diseases of the microbiota itself, and that's C. difficile colitis and related diseases. And for them, you can actually either cure or certainly bring under control C. difficile colitis. Then there are diseases that are directly affected by the microbiota that influence the interface between the gut lumen and what's going on the other side of the gut lumen at the interface, at the mucosa of the bowel. And those are diseases, mostly immune diseases, with innate immunity, things like Crohn's disease and colitis and things like that. Then there are the diseases that are affected by pathways, signaling pathways that are regulated by the microbiota. And finally, there are diseases that may be influenced by the microbiota, like brain diseases and other things like depression and other things like that. And those diseases are listed on the right here. C. difficile colitis in the first case, inflammatory bowel disease and celiac disease in the second case. That's where we have the greatest amount of evidence. Fatty liver disease, obesity, diabetes, and other metabolic diseases are in the third category where we really haven't broken the code yet. And then the ones where we talk about things like irritable bowel, cognitive disorders, depression, and anxiety, and the like, we're pretty far from really understanding the relationship. So given the amount of time that we have together, and the fact that everything today seems to be running late, I will end there, and thank you for your attention.
Thank you to all our speakers. What an amazing variety of different topics.